here at UC Davis Medical Center. And I'd like to talk to you today about some of the controversies in the diagnosis and treatment of diabetes, some of the changes that we have to think about when we choose different treatment options, and then hopefully at the end to answer some of your questions. I must disclose that I have no relevant financial relationship. And the specific topics that I'd like to cover today are the change in the diagnosis of diabetes using hemoglobin A1C, the change in the nomenclature and testing for pre-diabetes. Pre-diabetes used to be the old impaired fasting glucose, and there now is a new term, and so I'd like to talk to you about that. I'd like to bring you up to date on some of the controversies around tight control of diabetes, how we use the hemoglobin A1C to make a decision, and just how tight we can go with glucose control. I would also like to talk a little bit about the thiazolidinediones and some of the information that I'm sure all of you have heard recently in the news about whether thiazolidinediones are safe for our patients, or are they so risky that we should not use them? And then I'd like to spend a good bulk of the time talking to you about therapy for type 2 of diabetes, when we should be choosing certain therapies, and as our patients progress through their disease, how we might adjust the medications. I'd like to do this by introducing different patients to you so that it can highlight what we should be thinking about and talking about. So in our first case study, it's a 65-year-old man who had a recent lab work and had the following results. Hemoglobin A1C was 6.5%, fasting glucose is 124 milligrams per deciliter. And the new question now is, does this patient have diabetes? And what are the criteria for diagnosis of diabetes? The ADA comes out each year, this is the American Diabetes Association, comes out each year with its recommendations both for treatment and diagnosis. And this year in the January issue of Diabetes Care, they released their updated and summarized criteria for diagnosis of diabetes. And for the first year, hemoglobin A1C has been included. And if an individual has a hemoglobin A1C of 6.5%, then they are likely to have diabetes. The old information still stands. That is a fasting plasma glucose of 126 milligrams per deciliter, or a 2-hour plasma glucose greater than 200 milligrams after an oral glucose tolerance test, or a random glucose at any time of greater than 200 with the classic symptoms of hyperglycemia. So for our individual, he does meet the new criteria. He has a hemoglobin A1C of 6.5%, and he does have a fasting plasma glucose of 126 milligrams per deciliter. Our second patient is 46, and she comes in for routine lab work. She's feeling totally asymptomatic. She had these labs. She had a hemoglobin A1C of 5.8% and a fasting serum glucose of 100 milligrams per deciliter. And the question to us now is this abnormal? Previously, the hemoglobin A1C was thought to be normal up to 6%. Now the American Diabetes Association has recognized that individuals with hemoglobin A1Cs of anywhere from 5.7 to 6.4% may not have true diabetes, but they are at risk for developing some of the complications that we recognize, particularly early coronary artery disease or early microvascular disease like peripheral neuropathy or kidney disease. So because of this, they have changed the criteria. And so now the old term, impaired fasting glucose, impaired glucose, or prediabetes, is for those individuals who have a hemoglobin A1C that's in the 5.7 to 6.4% range. And they've again changed the term. So instead of prediabetes, it is now a term that's meant to describe what these changes mean, and it is an increased risk for diabetes. They've also reaffirmed the fasting glucose levels. so that someone, the normal is between 70 to 99, and that an individual with a fasting glucose of 100 to 125 does not have a normal glucose, and they are have an increased risk of moving on to having outright diabetes. Also, they have left unchanged the 2-hour oral glucose tolerance diagnosis of 140 to 199 at 2 hours. So if we have a patient who has a hemoglobin A1C or fasting glucose levels that are in the impaired or the at risk for developing diabetes, are we supposed to treat them? Are we supposed to offer therapy for them? And the answer is yes. And lucky for us, the therapy is what we normally would acknowledge is important for us, for any individual, for just general good health. And the first and foremost is weight loss of 5 to 10% of their body weight, and then increase activity. And the suggestion now is that individuals should have at least 150 minutes a week, which turns out to be 30 minutes a day, 5 days a week. For those individuals for whom that you have high concern, metformin can be used. There are several studies that tell us that metformin can prevent the progression or can be useful in keeping individuals from moving on to the next stage once they have been diagnosed with this at risk for diabetes. And those individuals might be in hemoglobin A1C greater than 6%, those that have outstanding hypertension, and those with a very low HDL. These individuals you might choose to, besides weight loss and increasing their physical activity, adding metformin. And if you and your patient make the decision that you are going to use lifestyle management, then you might want to consider monitoring for development or movement onto diabetes every 6 months to a year. Now, one of the other changes that we're beginning to see in our lab tests, besides just the hemoglobin A1C and the change for what was considered to be normal, a lot of our labs are also giving us an estimated average glucose. And what this is meant to do is describe, or in terms that our patients sometimes have an easier understanding of, to explain the hemoglobin A1C. Sometimes the hemoglobin A1C can be abstract, whereas some of our patients understand that my glucose is 200, my glucose is 100. They might be able to understand that. So the estimated average glucose is a way to describe at a certain hemoglobin A1C level what the glucose might mean. So at a hemoglobin A1C of 6%, the estimated average glucose is 126 milligrams per deciliter. Or when the hemoglobin A1C is at 9%, the estimated average glucose level is 212. This then can represent the hemoglobin A1C somewhat better to our patients. So what is the goal of the hemoglobin A1C? What is a safe goal? Previously, we were trying to rearrange our therapy, help our patients to get as low hemoglobin A1C as possible. And is this what we still should be doing? There is no question that the lower the hemoglobin A1C, there is a decrease in the microvascular complications of individuals with both type 1 and type 2 diabetes. And this means that patients' risk for eye disease, neuropathic disease, eye disease, kidney disease are all definitely decreased the lower the hemoglobin A1C is. But there's been many studies in the last 2 to 5 years that tell us that maybe for our patients with type 2 diabetes, that they might have an increased cardiovascular risk if we lower their hemoglobin A1C too quickly, or if we lower it into a too low range. To help try to answer this, the researchers that were a part of the United Kingdom diabetes prevention study looked at some of the data that they had on about 30,000 patients to look at what the hemoglobin A1C was, how low they were able to get the hemoglobin A1C, and then what the event rate was, how often patients were having strokes, heart attacks, how often they had to have coronary revascularization, to try to begin to answer whether the hemoglobin A1C or how high the glucose levels were made any difference. They looked at two separate groups of individuals. Cohort 1 were individuals that were switched, that were only on one pill for their diabetes and then were switched to a second pill. Cohort 2 were the group of individuals that had already on 1, 2, or 3 oral medications, and then insulin was added to see if there was any difference in shifting of therapy. They found that those individuals, as they were shifted, had a slightly increased death rate, but those individuals for whom insulin was added had a greater death rate. They then took a look at the hemoglobin A1C. So what we're looking at here is a plot of individuals, their hemoglobin A1C, and their risk for having a major large vessel event. That would include MI, that would include a stroke, or having to have coronary artery bypass grafting or a stent. And these individuals are those individuals that are considered to be normal. And we find without any great surprise that those individuals out here with a hemoglobin A1C of 10% or higher had a very high rate of having coronary events. And it seemed to decline generally, and once the patient's hemoglobin A1C got into the low 7% range. But what was a great surprise as that the lower the hemoglobin A1C went, the higher their risk for having a coronary event. If we look at, if we separate out therapy, this therapy are individuals that went from a single agent to 2 agents. These individuals were already on an oral agent and insulin was added. So if we look out here at the hemoglobin A1C, we find that those individuals who had very poor control had the greatest risk for having a coronary event, and that their risk did go down until about somewhere in the mid 7% range. And then their event rate, their risk for having having a coronary event started going up after their hemoglobin A1C dropped. These individuals were individuals where insulin was added. So just as those individuals with oral agents, individuals with diabetes, once you dropped their hemoglobin A1C somewhere between the 7 to 8 range, there was a dramatic decrease in their risk for having a coronary event. But if you attempted to push the hemoglobin A1C much lower, the event rate went up to a much greater degree. So what does this mean for us? It means that we must understand these individuals a little bit more clearly, who they are, how long they have been having high glucose levels, and we have to make a decision, has our therapy increased their risk for hypoglycemia? Are we controlling their blood pressure and lipids well enough? And if we are going to try to improve their glucose control, possibly we must do this in stages. Maybe it should be that we should go more slowly down to a target hemoglobin A1C and then plateau out. And how long we're supposed to plateau out isn't really clear, but it certainly probably will mean that we're going to have to plateau out months, years, maybe, before we try to normalize these individuals. Now, there is a lot of worry and concern about whether agents that we use for controlling the glucose levels, are they in some way harming our patients. They certainly are very useful for lowering the glucose level, but in the process of lowering the glucose level, is there something about these agents that is causing more harm than good? Certainly the biggest controversy right now is whether pioglitazone and rosiglitazone cause an increased risk for heart attacks, and is there a difference between the pioglitazone and rosiglitazone? Is one or the other of them safer to use? This is a very busy slide, and I will go over this slide for you because it's important for us to understand some of the concepts that are being shown here. First of all, down here are comparisons of different medications. Now, we already know from the UKPDS and a few other studies that those patients on metformin have a decreased risk for coronary artery events. They have a decreased risk for strokes and for heart attacks, so myocardial infarction. So that in this group of individuals, when they looked at the data, they looked at most of the therapy we use against metformin. And that's what you see in the red line here. This is metformin being having the lowest risk or being the most beneficial, and the therapy being compared to metformin. If it is above the line, then the therapy is causing greater risk for myocardial events. If it's below the line, then possibly it's more protective. So if we look at these individuals, I've put them out here for you. So the one here is the first generation sulfonylureas, which we rarely use anymore. These would include chlorpropamide and Tolinase, but these are used in a small, to some degree, by certain health groups. The second generation are the ones that we're used to using. This would include glipizide and glyburide. Then in this group, we are looking at rosiglitazone against metformin, pioglitazone against metformin, and then trying to look at whether pioglitazone or rosiglitazone are more likely to cause an event. And then all other combinations, that means all combinations like insulin and all the medications against metformin. So if we look here at first generation sulfonylureas, we find that the risk for a coronary event does go up. If we look at the second generation as compared to metformin, there's no question that there is a slight increased risk for coronary events using these medications as compared to metformin. If we look at rosiglitazone versus metformin, if we look at myocardial infarction or congestive heart failure, it's unclear whether with the current data that we have, that there are greater risk for myocardial infarction with rosiglitazone. Certainly, we've known for a long time that both the TZDs, pioglitazone and rosiglitazone, will increase the risk for congestive heart failure, and this data analysis seems to show this. And then all-cause mortality, it seems to be equivalent to metformin. When we actually look at pioglitazone against metformin, we begin to see possibly a difference in that the myocardial rate seems to go down slightly with pioglitazone as compared to the metformin. The congestive heart failure rate is either equivalent or slightly above metformin, and all-cause mortality goes down because with the pioglitazone. If we compare rosiglitazone against pioglitazone, it appears from this data analysis that rosiglitazone has more risk for myocardial infarction, has an equal risk for development of congestive heart failure, and all-cause mortality might be increased. Because of this worry and concern, there was a study that was started in May of 2009 looking at rosiglitazone, and it's called the TIDE study. It's going to be going on for 5 years, looking specifically at the risks of myocardial events. I don't know whether the study is going to be able to be completed. As you well know, the FDA is currently looking at rosiglitazone and whether it should stay on the market. And what I've been telling my patients now is that both pioglitazone and rosiglitazone have their place in therapy. And I would like to talk to you possibly about how the TZDs as a whole might be used. The information that we're going to need to tell us whether there might be a danger with either one of the products hopefully will come to us soon. If we look at this one study, more recent, took all the studies that were available for rosiglitazone and most of the studies that were available for pio and just put them together, looking at the risk for a myocardial event. And this is the line, the neutral line. If you are to this side of the line, then there might be an increased risk. If you look to this side of the line, that there might be decreased risk. And this is the hope that the TIDE study will answer the question of whether there is or is not an increased risk. What I would like to do now is talk to you about what therapy we have available and talk to you about first the sites that are trying to be adjusted because of the therapy, and then do some case studies to help try to make a decision at different stages of a diabetes, an individual's diabetes maturation, what therapies might be better for therapy. Are there certain therapies that we should be giving early on? Are there certain therapies that we should be saving for a later date? What therapy, and then overall just what therapies are available. The medications that we have available to treat diabetes are directed generally at a specific abnormality of the diabetes. And for a long time we've known, and we have always had therapy that was directed at the liver, and this would be the metformin. We've had therapy directed at the pancreas to try to improve pancreatic function. We've had several therapies that would help us improve muscle ability to uptake glucose. But now we have many more therapies that help us improve or take advantage of some of the abnormalities that we have with individuals with type 2 diabetes because we have somewhat of a better understanding. When we uptake glucose, all of these organs that you see here interplay and help make the decision about what will happen, how that glucose will be disposed. The brain helps make the decision how much glucose we're going to take in with our appetite, when enough is enough. Our gut absorbs the glucose, and once it is absorbed, it sends out messages both to the liver and to the pancreas to get the body ready to shuttle and do something with the glucose. When we have areas to dispose of the glucose, which usually include the muscle, the liver, and the adipose tissue. When we look at some of the problems that can occur over a long period of time with someone with diabetes, we have to look at particular organs because of the special changes and some of the ways that we must understand what's happening to individuals over time. Early on in someone's life, when they either don't have any evidence of the diabetes or they are in the pre-diabetes or at risk for diabetes, the pancreatic function is quite good. It is instantaneously responsive. As an individual gains weight, the pancreatic beta cells where insulin is made begin to hypertrophy. They get bigger to help out as the individual's total body mass increases. particularly the adipocytes or adipose tissue, as that increases, the beta cells also increase. There gets to be a point, though, for some individuals in which the beta cells can't keep up, and they start to decrease in size and diminish. And then if individuals stay at a very large rate, do not exercise, aren't changing what they eat, the beta cells actually can diminish and quit producing. They can atrophy down. And over time, with a patient with diabetes, the amount of insulin is markedly decreased. So it's important that we understand then that in order to lower the glucose level, there are many different ways that we must help the individual. First is obviously with decreasing the loads of glucose that the individual gets. And this has to do with a change in diet. Also, we can then improve how the individual deals with the glucose by increasing muscle mass and increasing the amount of glucose that is received. We can also increase the amount that the liver sees, but there are certain organs after a short time that become less effective. Messages become skewed. One is the crosstalk, or what the islet cells are producing when hyperglycemia is present. Certainly the pancreas increases insulin secretion, but it also increases glucagon. Glucagon resists the effect of insulin and thus further leads to hyperglycemia. Often, one of the shunts that is available to our patients to help get rid of glucose is through the kidneys. The kidneys can decrease absorption of glucose, allowing it to be urinated off. But one of the problems that can occur is that the cues that the kidney receives is not to let the glucose go, but to reabsorb it. So there are agents that are available for us to target each of these sites. And if you would take a look at the handout that you have, hopefully it is there sitting for you on your tables. And at the top of the sheet it says treatment options and effect for diabetes. And what I've listed for you is the site of the abnormality leading to the high glucose level. And we start over to the far left with the muscle that there's increased insulin resistance. Then for the fat cells, the abnormality is excess amount of fat leading to lipotoxicity. The liver, the next site is the liver, in which it starts releasing increases amounts of glucose. At the pancreas, there is pancreatic insufficiency with decreased insulin and increased glucagon excess. In the GI tract, there are substances that are made by the GI tract that will actually limit the amount of absorption of the glucose. But as time goes on, for most individuals with diabetes, there is normal absorption of nutrients, and so each individual gets a full complement of the fat and the glucose. So possibly there might be something we can do with the GI tract. And at the brain, one of the abnormalities is that the brain does not sense any longer when the excess energy is available or not needed. So there might be certain therapies that would be available to let the brain know that there's enough nutrition. So the therapies that we have available to improve insulin resistance are the thiazolidine diones, pioglitazone, and rosiglitazone, Actos, and Avandia. To decrease lipotoxicity, we have thiazolidine diones, and there are newer studies where salicylic acid is used to lower lipotoxicity and actually is available, will be available to lower the glucose levels. To decrease the amount of excess liver output, we have metformin. To improve insulin secretion, we have the sulfonylureas and the faster acting meglitinides. And to lower glucagon excess that resists the effect of insulin, we have both exenatide and sitagliptin. Exenatide is Byetta, the injectable medication, and sitagliptin is Januvia, the oral medication. For the GI tract, to try to either limit the amount of absorption, we have the bile acid sequestrants like Ally or Welchol that lower the absorption of fats. We have the alpha glucosidase inhibitors like Acarbose that decreases the absorption of carbohydrates. And then we have the incretins, exenatide and sitagliptin, and I will talk to you about how they might work. And then for the brain, to basically decrease the appetite, we have the incretins like particularly exenatide and an amylin product called pramlintide. In order to figure out how we might use these medications, I have some case studies that I would like to go over with you, and I'd like to introduce to you how the medications might be used and at what stage. If we look at this slide, just mentions what I have in the handout for you about where each of these individual medications are working. And as we do our case studies, I would like us to assume that at all times diet and exercise will improve glycemic control, that many times they are the most powerful ways that individuals will change their glucose. But if we have gotten to the point where diet and exercise have reached their maximum effect, then we must use medications. And then I'm going to assume when we talk about these case studies that individuals, where it's appropriate, are already on aspirin, they're already on a lipid-lowering agent, blood pressure medications, and they have no overt heart disease. And then at the end, I will take questions that you might have for those that would have overt heart disease, what we might change. For our treatment choices, let's talk about the individual who is at the early stages of diabetes. This individual comes in for a physical exam, maybe feeling a little bit tired. Body mass index is up at 33. Fasting glucose level is in that at risk for developing diabetes range at 100 to 125 milligrams per deciliter. And the hemoglobin A1C by the new standards are definitely in the higher range. And what are the treatment options for this individual? So what are the medication options? Well, for this individual, you would like to decrease the progression. You want this individual to lose weight if it's at all possible. You want them to not progress to the next step if possible. So if the diet and exercise are to the limit that this individual can undertake, then the medication obviously to start with is metformin. We have a lot of experience with it. There are several studies that tell us that it might help us prevent progression, and metformin can certainly treat high glucose levels. Where the medications that also might be useful for us at this time that are not often used but may be a possibility are those medications that if you look at your handout under the GI tract, the medications such as the bile acid sequestrants and the medications that slow the absorption of carbohydrates can be a great choice at this time. Often they can target meals. So if a patient is very responsive and very helpful, has done a good job at controlling certain meals, if they have a high carbohydrate meal, say for dinner or for lunch, then the medications can be used to target at that time. If for our next patient, their diabetes has progressed a little bit further. The hemoglobin A1C is 6.9%. Several members of the family have diabetes. The father had an MI at 65. The patient's BMI is high, similar to our previous patients. And this individual has progressed on to full diabetes. And what are the treatment options to help this individual? Well, certainly any of the medications on the list can be used, but there may be a few that might help the individual get to goal somewhat easier. Certainly metformin to start. We have a lot of experience with the sulfonylureas. The problem with the sulfonylureas can be, though, that there's an increased risk for weight gain. At this point, some of the medications that could be more weight neutral would be the bile acid sequestrants and the medications that decrease carbohydrate absorption, such as acarbose, and the medications that would possibly help to lower the glucose and possibly preserve beta cell function. As we saw in the slide when I was talking to you about how over time the beta cells can decrease function and insulin secretion can be lost, there are certain medications that may help us at this time continue beta cell function for a longer length of time. And those are the incretin medications, sitagliptin and exenatide. Sitagliptin is an oral medication that decreases glucagon excretion, and there are some studies to say that it might actually preserve beta cell function. So that if we are going to use this medication, it's best used early on, and our patient at this time, possibly with a combination of metformin and sitagliptin. Sometimes there are problems, though, with some of the insurance companies that may not allow the use of sitagliptin early on, but this individual is the type of individual that it actually might have the best benefit. If we look at what happens over time to our patients with diabetes, we find that any single agent, gradually over time, will lose effectiveness. And that's what this chart is meaning to tell you. That after individuals are started on any single agent, most of them do quite well, and then gradually over time, within 2 to 5 years, they lose complete effect. Part of it might be the worsening of the diabetes. Part of it might be how beta cell function is changing. And so because of this trend that is seen, it is possible some of the agents like sitagliptin or the agents that might be coming in the future might blunt this. There are certain medications that have already been shown to do this, the thiazolidinediones. If you look at this graph, you get improvement, and then the medications begin to fail. With the thiazolidinediones, both pioglitazone and rosiglitazone, you get a dramatic decrease, and it seems gradually over time that the control maintains. And there may be several reasons for this. One is the improvement in sensitivity at several organ sites. The other might be the protection of the beta cells, and that's not clear. The only reason why there may be pause to consider using the thiazolidinediones completely is until we get that final information about the long-term risks, in particular for rosiglitazone, and that would be the increased risk for cardiovascular events. In our next patient, who is hemoglobin A1C is considerably higher at 8.5%. This patient has had diabetes for a longer length of time, for 7 years. This individual has peripheral neuropathy. The current therapy is metformin and glipizide. The body mass index is very similar to our patients previously, and it's really clear that our patient fasting glucose is not at goal, and the spot urine microalbumin to creatinine ratio is elevated, and the normal is 30. So this individual has a high body mass index. This individual has microvascular changes. They already have peripheral neuropathy and microalbumin secreting nephropathy, and it would be helpful to control these to lower the glucose levels. What we have to think about is how low we need to go in order to prevent the neuropathy and the nephropathy for continuing on. And if we look at all the previous studies, the lower the hemoglobin A1C into the 5 or 6% range, the less risk there is for, the greater chance there is for reversal and decrease for progression. But with all the information that we have had about the possible danger of dropping the hemoglobin A1C to a super low range, then we have to give pause a moment for what our goal is going to be for our patients. And certainly, an individual here in the 8.5% range, the goal probably would be in the 7 to the 7.5% range until they're stable, until their cardiovascular risks are controlled, and until you're sure what more that needs to be done cardiovascular before dropping it lower. To consider the medications to consider at this time can be any of the medications that are available. Now, if for the TZDs, they could still be quite helpful at this time at lowering the hemoglobin A1C. They also, both of the TZDs, pioglitazone and rosiglitazone, are going to cause weight gain. So that gives us pause when we're thinking about the body mass index of 33. Also, in the life of an individual with type 2 diabetes over many years, there is some risk that we have to think about for congestive heart failure or cardiovascular events, and so that would have to be explored before the TZD would be considered. Now, this individual might have a very good choice. One of the therapies that might actually be very good for this individual is to consider one of the incretins, either sitagliptin or exenatide. Exenatide in particular can help some individuals lower their body mass index as well as controlling their glucose levels. If we look at the difference between sitagliptin and exenatide, sitagliptin is the oral medication Januvia that's given once a day. Exenatide is the injectable medication that's given subcutaneously before breakfast and dinner, and comes in 2 doses, 5 micrograms and 10 micrograms. If we look at in a patient who has a similar profile to our patient about how well the exenatide or sitagliptin work, we find that if we look at a patient without therapy, their postprandial glucose can get up into the 240 range. With sitagliptin, the postprandial rise is lower, but it is not as good as exenatide. So if we look at the glucagon levels in these individuals, what exenatide and sitagliptin do is help decrease glucagon levels so that the insulin that is being made by each of the individual patients can work longer and better. So if we look at sitagliptin, the pill, this is the glucagon level, and what we want is the glucagon level to go down after a meal, not up. So if we look at sitagliptin, there's no question that it can. It does blunt the effect of glucagon, but if we look at exenatide, it is a little bit more capable of lowering the glucagon level. So for our patient whose hemoglobin A1C is at 8.5%, who has some weight to lose, that possibly this patient would be better, we could get them a closer to goal with exenatides, lowering the glucose levels and helping them lose weight. And the sitagliptin might be better used by individuals that have a lower hemoglobin A1C, who have a much lower need for glucose lowering. There's some information that possibly both exenatide and sitagliptin equally may promote or support prolonged insulin production. This patient is quite out of control. Hemoglobin A1C is 11%. This individual has had diabetes for 12 years, currently is on metformin, glimepiride, which is Amaryl, and pioglitazone, which is Actos, and is taking close to the upper dose of the metformin and the highest dose possible for the other oral medications. And still the patient has not got to goal. For this individual, what I didn't put for you here is a sense of how long this individual has been out of control. There's no question that at hemoglobin A1C, the average estimated glucose would be in the high 200 to 300 range. And this individual needs slowly to be able to have their glucose levels go down into a more normal range. This individual may be the individual that you might want to step down, meaning that you wouldn't attempt to get their hemoglobin A1C from 11% down to 7% over a few month period. It's possible that this type of individual should be staged so that gradually over 6 months to a year their glucose levels are slowly dropped. And certainly for this individual, most likely the treatment choice would be insulin. Here in this slide I have for you, I had wanted to show you where I got this slide. It was a very recent article looking at different insulin regimen for treatment of type 2 diabetes. I have this slide, this is the same chart that you had before, but it's a little bit more expanded. And what they've done is looked at different types, different ways of giving insulin. They are looking at giving just prandial insulin. They are looking at biphasic, meaning either you mix a regular and NPH together, or you already use the pre-mixed insulin twice a day. They are looking at bolus insulin, basal insulin, that would be similar to glargine, and they are comparing to what happens to the individual from baseline. So, the important thing to notice about each one of these slides is that, particularly for the glucose levels, that it does not make any difference whether you use prandial insulin, whether you use background insulin, whether you use the biphasic or combined insulin. Each of these insulins work to lower the hemoglobin A1C. If you look at body weight, it really, that for most individuals, the basal insulin, seen here in red, causes less weight gain than does the biphasic or the prandial insulin. If we look at how the sort of overall amount of insulin, the overall weight as they improve their hemoglobin A1C, we find that the body weight tends to go up the lower the hemoglobin A1C goes. Insulin works whether the individual uses meal insulin, whether they use a split mix type of insulin. each insulin will work well to lower the glucose levels. The only thing that we have to remember is that if the studies are true, that the lower the hemoglobin A1C, the greater risk for a cardiovascular event for our patient, then we must be very careful, particularly in these patients with very high hemoglobin A1Cs, about how abruptly we lower them, and possibly the risk, we must decrease the risk for hypoglycemia as much as possible. Today I talked to you about several different things. One was the new ADA recommendations for change in using hemoglobin A1C as a means to diagnose diabetes. The new recommendation is that if an individual has a hemoglobin A1C of 6% or higher, they should be considered to have diabetes. They've also lowered and changed what is normal about a hemoglobin A1C, and that a hemoglobin A1C of 5.7 to 6.3% is not considered 5.7 to 6.4 is not a normal hemoglobin A1C, and that these individuals are at a much greater risk for moving on to developing diabetes, and possibly we ought to be intervening at that time. There are dangers to lowering the glucose level too rapidly. And the risk is increased risk for cardiovascular event. Certainly, we have to control the complications of diabetes, but possibly lowering the hemoglobin A1C to somewhere between 7 to 7.5% would be the most useful for our patients. And then finally, the medications that are available to us, any one of them can be very helpful for lowering the glucose. Any one of them can be used at any time or stage of diabetes, but there are certain medications that may not be useful for later diabetes that might be more useful at early diabetes, and that there are some of the medications that are available that might help support and prevent beta cell loss, and there are some of the medications that we have available that actually might help our patients to lose weight.